So chapter 34, chronic and degenerative neuro disorders. We'll talk through this PowerPoint and I'll kind of point out, I think, which disease processes are more important to sort of know and study. There's a couple in here that are interesting, but you won't necessarily take care of those patients. And a couple disease pathologies in this chapter that also won't be on the NCLEX or any other tests. So I'll kind of point those out, though they are very interesting. Neuro is a fascinating specialty, and if you wanted to go into this as a specialty area, I think you would thoroughly enjoy yourself. Here in Lincoln, they have the neuro patients tend to go to the Bryan West campus, but we see them on every floor because strokes are such a common disease pathology. But as far as head trauma goes, those patients will land at Bryan West and they'll start their journey in the emergency department at Bryan West. And we get head trauma patients from all over the state because Bryan West really is when Bryan West was originally Lincoln General Hospital, they started the trauma as its own disease pathology. So the worldwide trauma education that you take all actually started here in Lincoln, Nebraska at Bryan West. And so even to this day, we have neurosurgeons that work at Bryan West. Not every hospital in the state is lucky enough to have a neurosurgeon. Most hospitals do not. And there are more plain neurologists in the state, but a neurologist can't do brain surgery. And it is difficult to get in to see a neurologist. So if you feel like you're starting to develop Parkinson's disease, a lot of those guys have a 3 or 6 month waiting list. I would encourage you to think about doing that for a living, going on eventually become a nurse practitioner and specialize in this topic, chronic and degenerative neuro disorders. We need more mid-levels like nurse practitioners and PAs who specialize in this stuff. Some of the basic neuro concepts, you do have a central nervous system, that's your brain primarily, but also your spinal cord. Your spinal cord and your brain are connected as one whole unit. In fact, your cerebral spinal fluid, which resides in your brain, in the ventricles of your brain, it travels freely up and down your spinal cord into the brain. And so it's all one unit, the central nervous system. The peripheral nervous system are all the nerves outside of the spine, then the nerves in your hand, nerves in your feet, the nerves that innervate your heart. The autonomic nervous system is an example of the peripheral nervous system. The autonomic nervous system is divided into 2 branches, the sympathetic nervous system and the parasympathetic nervous system, the autonomic nervous system. I would encourage you to study as much as you can about the SNS, the sympathetic, and the PNS, the parasympathetic. Most of the drugs you'll talk about in pharmacology hit one or the other. And when you get into your final courses, such as critical care nursing, sympathetic nervous system and parasympathetic nervous system. You have to understand those two. The SNF sympathetic is fight or flight. It tends to rev your body up, increases your heart rate. The parasympathetic is your rest and digest, your feed and breed, chills everything out. Sympathetic revs you up, parasympathetic chills you out. Those are both branches of the autonomic nervous system. Brain cells are called neurons, and neurons conduct electrical signals. Glial cells are all the other cells in your brain. You got tons of them that are not neurons. They're the supporting structures. Glial. The nerve tissue, your neurons, your brain cells, and there's a ton of them. Like if we were to count how many brain cells you have in your skull, there's more than there are stars in the sky. Probably the most mathematically complex object in all of existence is the human brain. Mathematically, we can't even compute how many neurons you have, how many brain cells you have. The interesting thing about this mass of tissue in your skull that we call your brain is every single brain cell communicates with the other brain cells. But not a single brain cell is touching another brain cell. So if you have a sensory impulse traveling along a nerve cell, it reaches the end of that cell, and that electricity has to now turn into a chemical because there's a gap. There's a gap between two brain cells. That's called the synapse. And inside that gap are substances called neurotransmitters. Those neurotransmitters continue the communication. They allow two brain cells to talk to each other. And there's a bunch of neurotransmitters. The ones that we know something about, there's probably 10,000 or more neurotransmitters. We know a little bit about acetylcholine. We know a little bit about serotonin. We know a little bit about dopamine. We probably know more about dopamine than any of the other neurotransmitters. We know a little bit about GABA, norepinephrine, and glutamate. The serotonin is a neurotransmitter that we have been able to replicate in the form of a pill, and that's what your most common antidepressants work on. Those are called selective serotonin reuptake inhibitors. And they tend to make you feel a little bit better, alleviate depression. They're not a cure-all. They probably fix 30% of the symptoms of depression on average. Selective serotonin reuptake inhibitors. Dopamine has a lot of functions. One major function is learning. And so studying pathophysiology, you are utilizing dopamine in your brain as a neurotransmitter. Learning. One thing that dopamine will teach you is that cocaine is amazing. Cocaine causes dopamine to flood your brain. And so the whole theory of addiction really centers on dopamine. Dopamine is the feel-good chemical. Video game developers use dopamine. They study dopamine in the brains of people playing their video games before they release the video game, because addiction has to do with dopamine, we think. Any good business model, any great business hits dopamine. Facebook knows exactly how much dopamine is released in your brain when you scroll down your Facebook newsfeed. It causes a rush of dopamine, a feel-good, addictive experience. So if dopamine and cocaine go hand in hand, GABA and alcohol go hand in hand. Alcohol tends to chill people out, and gamma aminobutyric acid is an inhibitory neurotransmitter for the most part. So alcohol causes more GABA to be released, which chills your brain out. We have medications. In fact, the medication most commonly prescribed for diabetic nerve pain is called GABA, gabapentin. Gabapentin we give every single day in nursing clinicals. Every single patient, every single day, they get their gabapentin because it's an inhibitory neurotransmitter. It helps tamp down the pain that people have in their feet, which is a very common side effect of diabetes. Norepinephrine is an excitatory stress hormone. Glutamate also revs things up. The nerves utilize sodium and potassium, the movement of ions, to generate electricity. As the sodium moves in and the potassium moves out, essentially what's happening is the charge of the cell membrane is changing. And so your electrolytes, especially sodium and potassium, are vitally important for nerve transmission. The myelin is a protective sheath around the axon of some neurons. What the myelin does is it speeds things up. The myelin sheath speeds up that electrical communication, dramatically speeds it up. The only real reason to know what myelin does is for two reasons: multiple sclerosis and ALS. Those two disease processes happen because the myelin sheath is degrading. The brain is divided into different areas. We talked a little bit about these last week. You got the cerebral cortex, the top part of your brain. That's where everything you do as a human is taking place. Cerebral cortex, the higher brain functions. The cerebellum sits on the back and bottom part of your brain, kind of like at the top of your neck, where your skull is attached to your neck. That's where your cerebellum sits. And that's all about balance and posture. The word ataxia means imbalance and gait disturbance. So people walk funny. If somebody's walking funny, we call it ataxic. Here's that slide again, which I believe was also in the stroke lecture. Front part of your brain, the most important part. That's the human part of your brain. Humans have the most developed frontal lobe of any animal. We don't have the biggest frontal lobe, though. The biggest frontal lobe belongs to the blue whale. And actually, elephants have a bigger frontal lobe than we do. If we were to weigh their frontal lobe, it's quite a bit bigger. What we do have, though, is more connections. The human brain has zillions of connections, especially in the frontal lobe. You mess up your frontal lobe, and the very core of what it means to be human can get destroyed. The first time that this happened in history was way back in the 1800s, a guy named Phineas Gage. Phineas Gage was a railroad worker. He was laying new railroad ties, and he was tamping down an explosive, and the tamping rod exploded. The whole thing went horribly awry, and the tamping rod stabbed him through the cheekbone and came out the top of his skull. He did not die. In fact, he just got back up, pulled the rod out, laid around for a couple days, and then was fine. He did not die. But that tamping rod destroyed his frontal lobe. And he was a completely changed person after that. His personality changed. And a big thing that the frontal lobe is for, executive functions. Executive functions are things that make us human, like the ability to inhibit an impulse. Inhibition is a feature of the frontal lobe. That's part of what makes us human. We can stop an impulse. Well, Phineas Gage lost that ability, and he very quickly got into serious gambling debt because he could not inhibit an impulse. Somebody would say, hey, you want to bet $100 that such and such, blah, blah, blah. And he would always bet the money, and very quickly became hugely in debt with gambling debts, impulsivity. The brain stem is very important for basic body functions. The midbrain, which is the top of the brain stem, vision, hearing, movement. The pons, consciousness and sleep. As you go down the list, the more primitive functions are taking place. If you think about the 1 million years that the human brain slowly evolved, the higher functions, the more human functions are at the top. And the farther down you go from the top, the more we have in common with other animals. So clear down at the very bottom, the brain stem, we have that in common with reptiles. We used to have a pet leopard gecko. And the leopard gecko, not a super intelligent person, but he could do certain things like he could hunt for live crickets. He only would eat live crickets. That's why we got rid of him. It was disgusting. You have to buy a box of live crickets every week. But the leopard gecko could scan the environment for two things. He would scan the environment for potential threats and for potential food. Other than that, he didn't do a lot of deep thinking. So the human brain shares that in common. We have a brainstem, and the brainstem's purpose is to scan the environment for threats and then look for food. There are different disorders that specifically affect the ion channels, like the potassium and sodium moving in and out. A good example would be epilepsy. Epilepsy leads to seizures, and seizures really look like just this electrical storm in the brain, like a lightning storm. We got all this firing of neurons, all willy-nilly. When we assess the neuro system, I would say the first thing to do to assess the neuro status of your patient, and this is 98% of your nursing assessment, 98%, is to say to your patient, hey, how's it going? How's it going? And if your patient says, it's going great, I'm having a good day, the hospital food wasn't as terrible today, you just made 98% of the assessment that you need to make. Your patient is cerebrating, he's mentating, he's thinking clearly. Is your patient thinking clearly? If he's thinking clearly and everything that he says makes sense, most of the rest of this stuff is just icing on the cake. It's kind of interesting. You can do the whole mini mental status exam and stuff. But if he's able to talk to you and he knows where he's at, that's all the assessment for the most part you need to make. But that is a very important assessment. If you walk in the room and earlier in the day your patient did know your name and where he was at, and now he doesn't, something huge has happened. If he's suddenly confused, something big has happened. And as nurses, we often don't know what that big thing is. Our job is to just notice. We just notice, oh, something bad has happened. We're going to make some phone calls, or we're going to call a rapid response. But we got to get this patient worked up. He needs a brain scan, he needs labs done, whatever he needs done. Our most important thing is just to assess the mental status by asking the patient a question or two. The second most important thing are those signs and symptoms of a stroke. Things like facial droop and slurred speech and ataxia. Nurses, I just noticed that fundoscopic exam is on here. You'll be taught that in your assessment class, how to look in people's eyeballs with the little device. Have you done that in checkups yet? Anybody? The fundoscopic exam, that just cracks me up that we even teach that. I think it's hysterical. No nurse in the history of mankind or womankind has ever done a fundoscopic exam with a little whatchamacallit thing that, what is that thing even called? You shine the light in their eyeballs. The fundoscopic one is when you're looking in their pupils at the retina, the back of their eyeball. And that little, do you know what I'm talking about? The handheld thing. Can't think what's called. I talked to my eye doctor about this, and I said, what do nurses need to know about looking at retinas through this little thing? And he said that even eye doctors, the most experienced eye doctors with the old school fundoscopic exam, can only see about 25% of the retina. So a nurse is only going to see 1%, if any. It's just not something we do. But I would encourage you, if you do have an eye doctor, they might ask you now, this has been a thing for probably the last 10 years now, they have an automated machine that will scan your back of your eyeball, do a fundoscopic exam, and they usually charge you an extra 25 bucks to have it done. I would, if I were you, I would pay that 25 bucks, because the fundoscopic exam from the eye doctor is actually the #1 diagnostic test that first tells people they have diabetes. People first realize they have diabetes after going to the eye doctor and get a fundoscopic exam. There's lots of other neuro exams that we can do, and we do those if we're concerned about the patient's mental status. We're trying to figure out if they've had a stroke or not. There are upper motor neurons, which is problem in the brain itself. And the lower motor neurons, problems where the nerves exit the spinal cord. Epilepsy, I'll just talk briefly about this. The biggest thing to know about this, you got an electrical storm in the brain. What do nurses need to know? What do EMTs need to know? What we need to know is what to do. What do we do when our patient is having a seizure? We don't necessarily need to know what type of seizure. We really don't need to know the cause of the seizure, even though it is interesting. My favorite seizures are the seizures caused by different drugs of abuse, specifically withdrawal seizures. The seizures we see the most in clinicals are withdrawing from alcohol or withdrawing from benzodiazepines. Somebody who is addicted to benzos, which are medications like Xanax, Ativan. Probably Xanax is what we see the most right now. Anybody that takes Xanax every day is at an extremely high risk of seizures when they try to quit. Same with alcohol. Anybody that drinks alcohol every day, very high risk for seizures when they try to quit drinking. So those are the types of seizures that we see the most, not your classic epilepsy. We don't see that a whole lot, because often those patients are well managed with their seizure meds. But in the hospital, we have patients withdrawing from alcohol every single day of clinicals, and we are assessing them for seizures. If you go back to the beginning of this PowerPoint, the alcohol and the GABA, the gamma aminobutyric acid. The GABA is a chill pill inhibitory neurotransmitter. As soon as you stop drinking every day, that GABA is permanently shut off and your brain just freaks out. As soon as you stop the Xanax, brain just freaks out. Seizures, tonic-clonic seizures. And so how do we treat these patients? #1 priority is keep them safe. And so we do that by making sure they don't fall out of bed and hit their head. #2 is their airway. because some people, when they're seizing, they can occlude their airway. So the number 1 and 2 priority, taking care of seizures, keep them safe, and protect their airway. When somebody does have epilepsy, often they will have an aura, which is a strange sensation right before their seizure. Then they have the seizure, which is called the ictal period. And when the seizure is complete, they have a post-ictal phase. The word you'll see the most in the doctor's charting is the word post-ictal, because a decent number of people fake seizures. Lots of people fake seizures. Those are called pseudo seizures. And the reason people fake seizures is to get that Ativan. Ativan is a benzo. Benzos are what we treat seizures with. And so the doctor is specifically assessing whether the patient was or was not post-ictal. If they are tired, confused, nauseated, and just wiped out, you know it's probably a real seizure. People that wake up immediately and say, man, I just had a crazy seizure, they are not technically post-ictal, and the doctor won't believe them that this was even a real seizure for the most part. Even though some people can have real seizures and wake right up. I've seen it happen. Whether or not they're post-ictal is a pretty good indicator that it was a real seizure. I would say, well, because I'm the psych instructor, I suppose, but well over half of the seizures we deal with are not real seizures. They're behavioral. But your head trauma patients, they can have real seizures. Stroke patients definitely can have real seizures. Brain cancer, the glioblastomas, they always manifest as seizures. What that means is the person is doing fine, life's great, everything's chill. Suddenly, tonic-clonic, full-blown, flopping around seizure, and that's when they are first diagnosed with brain cancer, especially the glioblastomas. Environmental stimuli can cause seizures. That's a real thing. I watched a show on Netflix this week, and right before the show started, there was a warning, and it said, warning, there's lots of flashing lights in this movie. If you have seizures, you might want to turn away, because some people do have seizures watching Netflix if it's a strobe light type effect. Probably the most ominous causes of seizures are the infections. Somebody that gets a brain infection of some kind. But probably the most common cause that I see and I do critical care clinicals and mental health clinicals, those two areas, most common cause are withdrawal from alcohol or benzos, benzodiazepines. For the neuro stuff, we're going to check the CBC. Why are we checking that? Because we're looking for infection. The CBC will tell us if the white count is high. And if the white count is high, this person has an infection going on. If they have an infection going on, that's ominous. Not a good situation to be in. We worry about meningitis, encephalitis, all those kinds of things. We worry about parasites, worms in the brain. We check the serum chemistry. That's all of your electrolytes, what we call a basic metabolic panel. The reason we check the serum chemistry, primarily, we are looking at the sodium. We had 2 patients this week in ICU who had seizures, came to the hospital. Their sodium was catastrophically low. You get your sodium too low, the magic number is 118. You get down to about 118, you will have a tonic-clonic seizure. You can try this at home if you'd like. Just drink 4 or 5 gallons of straight water. You'll drop your sodium, you'll have a seizure. Then you'll gork your brain, cerebral edema, then you'll die. So don't really do that. I was totally joking. Disclaimer. Super low sodium causes seizures. We got to work this patient up. We do a CAT scan, we'll do an MRI, we'll do an EEG. An EEG is where they attach like 20 electrodes to your brain and measure the brain electrical activity. So this slide is talking about how to take care of the patient during the seizure, protect the patient from injury. Protect the patient from injury. If they're standing up, you'll need to lower them safely to the ground. Move objects out of the way. We don't physically restrain people. I've heard of patients that have broken bones from a nurse trying to hold the arm down or something, and they can actually break a bone seizing. And we don't put anything in the patient's mouth. Kind of the old school thought was, oh, you got to put a wallet in the mouth so they don't bite their tongue off. But what happens is then they bite the wallet in half and swallow it. That tends to be the case. And so best thing is just don't put anything in your mouth. But we do want to place patients in the recovery position, which is on the left side. The real reason for that is people always vomit. They always vomit when they're seizing or shortly after. And if you're laying flat on your back and you puke, where's all that gonna go? You're just gonna breathe it right into your lungs. You're gonna aspirate. So knowing that this patient's gonna puke, they're gonna vomit, we turn them over, so that when they vomit, the secretions drain out of the mouth and are not inhaled into the lung. Seizures are, I think, scary for us nurses. When somebody starts having a full-blown seizure, it's pretty scary. The big thing is, don't feel like you have to do anything. You really don't have to do anything. You just have to make sure they don't aspirate on their vomit. A good thing you could do as soon as you notice the seizure is make a note of the time. It always makes you look good. Makes you look good if you're like, the seizure lasted exactly 3.4 minutes. People are like, wow. Because most of us nurses, we don't have that presence of mind. We're like, seizure, and we're freaking out. So if you look at your watch, 1:49 is when the seizure started. The second thing to look at, and actually more important than timing it is not at all important. If anything, just make up a time. Oh yeah, it was 3 minutes. The most important thing to look at is the wall behind the patient's bed to see if you have suction hooked up. Is there a suction canister on the wall with a tube and then a yank cower? A yank cower is the little hard suction thing. That's the best use of your time. Make sure that they're safe. Look and see if you have suction hooked up. If you know the patient is coming to you and you read in their chart that they have seizures, before they even get to the room, hook up your suction. Hook up your suction, because that's how you're going to suck that vomit out of their airway after they're done seizing. You're going to turn them on their side, and then you want to suction if you can. We treat epilepsy with anti-epileptic agents. Some examples are phenytoin, valproic acid, carbamazepine. The real med, though, that we use, we don't use those anymore for epilepsy. The real med that we use, Keppra, a medication called Keppra. So if you see Keppra on your patient's med list, you know they have seizures. If you see phenytoin or Depakote, which is valproic acid, or Tegretol, which is carbamazepine, if you see those meds, you assume your patient has bipolar disorder, because those are the meds first choice for bipolar disorder. Other than phenytoin, we do still use that for seizures, but Keppra is a newer med, and by newer I mean like 20 years ago it was invented, but it works so much better than the anti-epileptic drugs. The anti-epileptic drugs work great for mood disorders, like bipolar disorder. The book talks about headaches and tension headaches, migraine headaches. It talks about trigeminal autonomic cephalgia. It does talk about sinus headaches, brain tumor headaches, and brain tumor signs and symptoms. It also talks about trigeminal neuralgia, which is very interesting. That's just another chronic pain syndrome. That's a irritation of that cranial nerve. I'm kind of skipping those, the headaches and trigeminal neuralgia, because those are not patients you'll necessarily be taking care of in the hospital, on the hospital floor, but you will take care of Parkinson's disease every single day. You always take care of Parkinson's patients. Of all the diseases so far, this is the one I would study the most, Parkinson's, because for one thing, the rates of Parkinson's are increasing dramatically, particularly in the United States, particularly in the state of Nebraska. Why? Because of agriculture and the chemicals we put on our fields. Parkinson's disease. It's progressive loss of the dopamine-producing cells in part of the brain. The substantia nigra, I don't think you need to know that phrase, just the dopamine-producing cells in the movement part of the brain. Movements such as posture, standing, walking, and riding are affected. The core pathology of it is that the acetylcholine stimulates muscle movement while dopamine has an inhibitory effect, but now we've burned out all our dopamine. The dopamine depletion imbalance causes unopposed acetylcholine. So dopamine, when you see Parkinson's disease, immediately think dopamine. A decent number of people in the state of Nebraska have what looks like Parkinson's disease because they fried their dopamine with too much cocaine. Remember I mentioned earlier that dopamine and cocaine go hand in hand? You use too many drugs, cocaine being a classic example, but methamphetamine definitely does this too. We see more meth in Nebraska. Too much meth, you fry out your dopamine in your brain. 20 years later, if you're still alive, you now look like you have Parkinson's disease. You have trouble walking. You have a mask-like face, which means your face doesn't have expression like it used to. Michael J. Fox is the actor that has Parkinson. But if you ever look at Ozzy Osbourne, Ozzy had his own reality show a while back. He looks like a Parkinson's patient as well. I think that he did too many drugs. I don't know that he actually has the diagnosis of Parkinson's. Maybe he does. We usually don't know. Parkinson's has an accumulation of alpha-synuclein, which is an abnormal protein found in structures called Lewy bodies in the brain. There's a form of dementia called Lewy body dementia, and that's really your Parkinson's patient who now has what looks like Alzheimer's. Lewy body dementia. The classic 3 symptoms of Parkinson's, I would encourage you to memorize these 3 symptoms if you can. They will come back to haunt you on test questions throughout school. Bradykinesia. That's just a fancy word for slow. Brady means slow. Kinesia means movement. They move slow. A resting tremor. Often it looks like pill rolling. Anybody with shaky hands and slow movement. Then we look at muscle rigidity, what's called cogwheel or ratchet type movement. The way I would memorize these 3 signs and symptoms of Parkinson's is after class today, go to Walmart. Go to Walmart and people watch and see how many people have bradykinesia, a resting tremor, and ratcheting movement of their joints. And that is the classic triad of Parkinson's disease. You will definitely see it if you go to Walmart later today. And then TRAP is another good acronym for diagnosing Parkinson's: a tremor at rest, rigidity, akinesia or bradykinesia. Brady means slow movement. The A means no movement. Akinesia, no movement. And then they fall. That's the trajectory of Parkinson's. They start out with a slowing gait, becomes a shuffling gait. The top half of their body moves faster than their feet can catch up, and then they start falling. My uncle, Kermit, he has Parkinson's, and he is a farmer rancher, and the chemicals he put on his field probably caused it. He's also a high school math teacher out in western Nebraska. He had to go to the nursing home finally because he kept falling. That bradykinesia turns into akinesia. He's actually been doing great at the nursing home because he's a people person and he has tons of people to talk to all day long. He just talks nonstop. He's doing really well, but eventually that Parkinson's is going to get him. That will be the death of him. Levodopa is still the mainstay of the treatment. That's the medication. And we combine it into a form called carbidopa, levodopa, and the trade name for that is Sinemet. ALS is a devastating disease, and so is multiple sclerosis. Study those. If you work in long-term care, you've probably taken care of people with more end-stage, either ALS or MS. MS is a lot more common, it seems like, in long-term care. But of all the diseases in this chapter, I would study Parkinson's disease. That's the one you're going to take care of every single day. Huntington's, you will see I see it in my career probably every 5 years. That is a fascinating disease and a horrible disease. It's just a horrible disease. But it is also fascinating from a pathophysiology standpoint. 100% genetic. If you got it, you got it. And symptoms are just going to magically appear between the age of 30 and 50, and then you'll die. So you don't know you have it unless you've been genetically tested for it. 100% DNA, the cause, Huntington's.